I think you can break down the advances that are happening is how we get more information on molecular segmentation. It's not going to change the paradigm that's set, but how we make it more sensitive and specific. So there'll be stuff on 1Q, P53, whole genome sequencing. There was a nice talk on an ancestral index where you can define early stages of disease as being less genomically complex, whereas late poor prognosis groups are genetically complex. And so there's going to be more on that. The bispecifics are going to power ahead, and the CAR-Ts. So ASH is going to see us with kind of really novel information in those three areas. But beneath it all, I think there's another layer of the stuff that goes on, that needs to go on, that really is not quite ready for prime time, which are new targeted therapies, all sorts of different approaches to the therapy of myeloma. And I've always liked trying to kind of search out those kind of rare bits that are going to be informative in 5 years' time, because really you need to put a lot of effort into that area of disease.
I think the thing that I've found interesting at this meeting is that some of the science behind those clinical studies. So we all know, for instance, the Forte data, looking at the role of daratumumab and carfilzomib, and the data that has shown about improving PFS and response rates. But there's been some very nice data presented as well about their FISH results, about their PET scan results, about their MRD testing, about the circulating tumor DNA. And so all of those newer techniques that were are kind of hovering around in the background that we're desperate to bring forward. So as well, the role of mass spectrometry, they're all being used in many of these large phase 3 clinical studies. And I think the last kind of year or year and a half, the results of the clinical studies have been reported, and it's now nice to see that science being reported as well, because that's going to take us to that next step of where we want to go.
So the stuff that we haven't really seen yet, because it hasn't been around long enough, is the impact of single cell analysis on clinical prognostic indices. And there was some talk of that here, but we have data that we're presenting in ASH where we've combined whole genome sequencing, single cell analysis of the microenvironment, and how that governs MRD positive or negative after you've been exposed to KRD DARA. So I'm kind of excited about that analysis. And so I think as time goes on, we'll see more and more of these complex science, but integrative biology. You put clinic, sequencing of the tumor clone, the microenvironment, multi-level genomic analyses are really the next step. And I think there are data sets out there that are being made available and will be seen at ASH.
Yeah, those, just following on from that multi-level data stuff, there was some cool stuff presented about machine learning, and that in the title that already kind of turns me off. But what they'd done was they'd converted their MRD data and tried to look at how that might be prognostic moving forward, and come up with a computer algorithm that you could plug your data in on the internet and come up with a clinical answer. So although the title and the science turned me off, the way they twisted it round to apply it clinically, I thought was really cool. And that's where a lot of that kind of, that translational clinical bit is kind of going.
So like, that's the benefit of machine learning, personal prognostic indices, where you put your data in and it tells you what your prognosis is, not a group of 100 people. The downside of that data was at least 3 of the variables aren't available for all patients, and so we need to kind of see it applied more widely, but it's a great idea.